Oh, there we go. We're recording. Perfect. All right. So if anyone can't make it, happy to have them watch. Okay, so here's Tongue-Tied Academy. This is my COVID project. It was 25 hours. So it took a lot longer than that to make it. Obviously, it took about a year to write the script for this, and then it's an online course, A to Z, could teach anyone how to do tongue-tied releases. And so it's 25 hours of short video lessons. Think like the master class, like Samuel L. Jackson teaches acting, that kind of stuff. That style is kind of what we were going for. And then here's the update course. It was just released back in April, and it's, I think, 13 hours. And so it basically is an update because again, it was during COVID. The four year later, we have a lot more different protocols, that kind of stuff. So this is the update course. Again, same style. And then the live course. So that would be the proper order to take it to learn the most. If you just show up to the live course, you haven't taken Tongue-Tied Academy, of course, you're going to learn something, but I can't teach 25 hours in 8 hours of one day on Friday. So, but this is helpful for once you've got all that background knowledge, you can feel the restrictions yourself, see us do it, practice holding the laser, that kind of stuff. And then with all the money, we put do not disturb here. There we go. So with all that money, we're going to use that for wells, health centers, human trafficking projects, stuff locally as well as globally. And tonguetie.com, this is our most recent thing. Blair may not be aware of this one, but we just released this a few weeks ago, tonguetie.com. It's basically tongue-tie education support for parents and professionals. And so you'll see that family at the end of this series. Here's my girls. That's how I got in this mess in the first place. So here's Hannah and Noelle, our twins. My wife, Tara, is a nurse practitioner. She's currently staying home with our girls. And then Molly's our youngest. So Hannah and Noelle are 10, Molly's 5. And that was with Goofy on a Disney cruise back in March for spring break. It was a lot of fun. So most people that come see you guys know what this is right there? That's the struggle bus, right? They're not going to come see you unless they're really struggling, right? Just like I would never go to the endodontist to get a root canal unless my face was throbbing, okay? They don't want to have their baby lasered or their child lasered, right? So they're on the struggle bus. So to get them to thriving, which is the goal, it's really just basic medicine or dentistry. It's nothing earth-shattering here, but it's just getting like a methodical approach to it. You got to get a really good history, so asking the right questions, proper examinations. You have to know how to examine properly. We'll get you to the right diagnosis. Otherwise, you're going to veer off course. Then you have to treat it properly, not just a snip or a clip. You got to get the whole thing. Aftercare afterward, or else it'll grow back together, and then a follow-up to see what you missed or what got better, what didn't get better. And if you do all those things, you'll stick to the yellow brick road and then hopefully end up at your destination of thriving. Hope you like the animation. It took me a while to make that. So here's Molly. So she's 5. When she was born, she was 42 weeks in the belly, like would not come out. And it's like 4 days in labor trying to get her out, VBAC attempt. We got it. Took 4 hours of pushing from my wife. It was so rough, I was sore the next day. Okay, that's how bad it was. But we got her out, and then first cry, I was like, oh my gosh, it's like to the tip. Of course, I waited an entire 5 minutes before telling my wife there was a tongue tie. I was real proud of myself. And then on day 2 of life, we went and fixed it. So here's the lip beforehand. Lip's not terrible, but I was like, you know what? I have one chance to do this right. I'm just going to do it right. I was not going to just go do the tongue. No cheek ties, thankfully. So we just left the cheeks alone, but did the lip and the tongue. And the power was out. Of course, the power was out. Like never happens. So I got a battery backup. So if you have a laser, you can grab your battery backup off your computer. If you don't have one of these, it's super helpful. You just plug in that and it still works. So that was great. And I had to do it in the hygiene bay because we didn't have any power, so I couldn't lay the chair back. But anyway, so there's was mouth breathing, tongue down posture. Now her tongue is up afterward. And then she gained 1 pound a week for 7 weeks and got really super chunky. She was like 20-something pounds, 23 pounds at 6 months old. She was quite large. And she started talking early, walking early, all these things. So if we left her tongue how it was, almost to the tip, there's no way she'd be able to sing like that. Like I'm going to show you right now. There's no way. She said the Pledge of Allegiance at 2 years old. Like there's no way that would have happened if her tongue was that tight, right? So here's her singing her song. This is this is earlier this spring. That's Molly. She's our little ray of sunshine. She's so fun. She just made up that song, and that's her microphone with the stick. But so that's what we want. We want thriving kids, right? We want them not just to survive, not just to gain weight, but to thrive and, talk well, eat well, sleep well, all the things. So how are we going to get there? We need a paradigm shift. This is the key. So the old way, and this works really well for like a toothache, right? I did this yesterday. I was at the hospital today at Children's, had 6 cases today. I was at the office yesterday doing some dentistry and some tongue ties. But so if you have someone comes with a toothache, hey mom, what's going on today? It's hurting. When's it hurting? Hot and cold at night, waking them up, that kind of stuff. We'll take a look in there, take an X-ray, get the tooth out. So snip or clip. There's nothing really to do afterward. Don't suck on straws, that kind of stuff. Soft foods. Follow up as needed. Just give us a call. Again, works really well for toothache. If you apply the same thing for tongue tie, it does not work as well. So this is what typically happens at the pediatrician, the ENT, that kind of thing. Hey, mom, what's going on today? We're having some trouble nursing. Okay, let me take a look. They'll maybe get like a tongue depressor, a finger caught, right? Take a peek in there. Doesn't look that bad, or maybe a little bit. Here, I have some scissors. We'll clip it halfway. No stretches are needed. Nothing to do. Call us if you need anything. Surgeon only, maybe lactation, maybe a speech therapist. If you add all that up, you're going to get minimal results, right? So really what we need is a new paradigm. So we're going to do a comprehensive history. So we're going to use our 50-item questionnaire of all the things we've seen improve afterward, right? That's the key. You got to know the right questions to ask. Get a full exam. I'll show you that. And this lecture is like intro lecture, but also have some advanced stuff for people that have heard me speak before. So hopefully it'll be good for everyone. But full release of restricted tissue. Stretches 3 times a day for babies, twice a day for kids like 12 months and up is what we've moved to. For about 4 weeks is how long, that's about 28 days is how long wound contraction phase is typically for wound healing. Follow-up mandated. What do I mean by that? Well, in person or virtual. So our previous record for the longest drive back to our office for a follow-up was 10 hours from Houston, Texas. We had a family from Houston come see us in Alabama, and they drove back 10 hours. Someone just beat them, though, on Monday. It was 11 hours. They're from Vieira, Florida, which is like near Melbourne. Drove back 11 hours, but their child was choking, have all these issues. Now he's doing so much better. I'll put that on our Instagram sometime later this week or next week, but I got to like edit it and stuff. But anyway, I have lots of videos from like the family, and the little kid was saying some really cute stuff. He was 5. So follow-up mandated. Most of the time that's in person. So if they're within like a couple hour radius, 2 or 3 hour radius, we'll try to get them back in person. If they're further than that, most of the time we do virtual. So like not Zoom, but like just to take pictures and send it to us, and then we'll follow up with them on the phone. With a team approach. So lactation, working with PT, the chiropractor, working with OT, speech therapist, myofunctional therapist, the pediatrician, ENT, all the people, right? If you do all that, right, add that all up, you'll likely get impressive results. Now, nothing's a guarantee. Nothing's 100%. In fact, if I said it's 100%, then it won't work for you, right? That's what I tell people, but it's like high 90% when you do that, if you do it the right way. So these are infant forms, so under 12 months. On this side, it's kind of sneaky. These are more, these are more tongue tie issues. On the left, these are more lip tie or buccal tie issues. On the bottom here, these are mom's issues, okay? And then we also ask, how are you doing mentally, emotionally? Every day, we check moms for postpartum depression with the EPDS-10. That's what they use at the OBs typically. And every day, we get people scoring above a 10 on that, which puts them at a higher risk of postpartum depression. And they're really on the struggle bus. We had someone score a 13 on Monday, for example. And I said, do you have much good support? She's like, not really. I have my husband, my family is far away. They're a military family. So anywho, shallow latch to the breast, falling asleep in the middle of feeding. They're not efficiently feeding. They're popping off and on the nipple, gagging, choking, coughing, slow weight gain. What's interesting is a lot of babies we see are not having weight gain issues, but for the pediatricians, that's the number one thing they look at. Are they gaining weight? They're gaining weight. They're fine. They're going to live. Like that's not, the bar is like down here. We want the bar up here, right? We're going to raise the bar. I want them to thrive and not just survive. Hiccuping a lot, and then in utero hiccups. The in utero hiccup is probably the earliest sign of a tongue tie. It's in utero hiccups, like excessive. Gumming or chewing the nipple, passy won't stay in, snoring, noisy breathing, mouth breathing. Think about these airway issues we see in kids later, in adults with sleep apnea. It's a continuum, it's a spectrum. It starts in infancy. So we fix their tongue, it goes up. They stop mouth breathing afterward. It's pretty cool. Short sleeping, they move a lot in their sleep. They're always hungry. Delayed crawling or walking. We've seen some babies that are 12 months old not crawling. We do the tongue tie. The next day they start crawling. It's not a coincidence. With 18-month-olds not walking, the next day or within a couple of days they start walking because they can move easier, right? They're sleeping better, all kinds of stuff. The seal issues is like lip curling under, clicking or smacking noises, sucking blisters, colicky, reflux, spitting up, gassy. It's all from swallowing too much air. The milk leaks out of their mouth, constipation, all those things. Bad pain for mom down here. Often it's like a 7+ pain. We had one just yesterday. Mom was a pediatric dentist from Chattanooga. Dad was like well, I don't want to give away because I think they actually were in, I don't want to give away who it was with HIPAA reasons, but they did residency in Houston, I think. And so you guys might know them. But anyway, won't say what the dad does, but he's a physician too. And it's terrible pain, 7 out of 10 pain nursing. We did it. It was not obvious. It was the less obvious tongue tie. So that's what I was getting at, is the less obvious tongue ties cause horrendous pain for mom. So if you peek in there and they say they have all the symptoms of a tongue tie, don't say, oh, there's nothing there, or, whoever told you there's a tongue tie is crazy. That's not the case. It's just a little bit there. And for that individual child, it's too tight. So we released it. We did the lip and the tongue. Later that night, I called to check on him. Oh my gosh, this is the first time we've been able to nurse our baby. She was, I think, 6 weeks old and was really struggling a lot. And like mom's like feeling confident, okay, we can do this. And it doesn't hurt anymore, right? So it's huge. Poor breast drainage, plugged ducts, nipple thrush, feelings of hopelessness or depression, right? Cut, blistered nipples, bleeding nipples. Like no one wants that, right? If your knee was bleeding, had 7 out of 10 pain, you're like, there's something wrong with my knee, right? So what they're getting right now is symptomatic relief. So they have, they're gassy, here's some gas drops. They're colicky, here's some gripe water. They're spitting up, here's some reflux medicine. Sorry, that can also cause bone fractures later on, but don't worry about that. It hurts, here's a nipple shield. It really hurts, here's some formula. What did they get? A family pack of Band-Aids. A family pack of Band-Aids. So what are we doing? We're looking deeper at the root cause, which is often, but not always, a tongue tie or lip tie, right? There could be multiple things going on. They could have torticollis. They could be in fight or flight and sympathetic and like freaking out all the time, right? These babies come out and there's all kinds of, trauma and things from birth. But what happens if you don't fix it? Well, speech issues. So speech delay, we see kids improve in speech afterward. Even this week we saw it, right? It's on our Instagram. Frustrated, embarrassed, they're bullying, which could be actually be both sides of the bullying picture. They could be made fun of because of their speech, or they could have aggressive behavior because not sleeping well. Trouble swallowing, slow and picky eating. It's so common. It's about 1 in 4 kids. Any given classroom, right? Whatever, doesn't matter the classroom size. Whoever's the last one to finish their lunch probably has a tongue tie. They also probably are having airway issues. They have poor sleep quality, poor behavior, hyperactivity, may have had issues as a baby with nursing, that kind of stuff. Some of you right now are like, oh my gosh, this is Johnny, this is my child. And wait just a second, we'll get there. But all these things, right? ADHD symptoms. It's not true ADHD. Often they're just not sleeping well, right? Teeth grinding, so bruxism. Those kids come in, their teeth are just flat. That's a problem. That's not normal. It's common, but not normal, right? Can affect their brain development. Newborns, their brain is developing at 1% a day. By the time they're age 3, their brain is 80% the size of an adult brain. By the time they're age 5, it's 90%. So we got to get these kids early. The earlier, the better. Reflux and constipation. If the food doesn't start the journey right, it won't end the journey right. I didn't believe it at first either. I was like, that's wacky. Like people kept coming in saying my kid's less constipated. I was like, no, there's no way. And then after like a dozen people say the same thing, it's like, well, maybe there's something there, right? Sleep and airway issues. So mouth breathing is how it starts. Gets to snoring, sleep disorder breathing, OSA. It's a continuum. Bruxism. They're kicking every which way. So anyone have a child that's like moving all over at night, you can't sleep with them. They also have their mouth open or their teeth grinding. They're sleeping with their bum in the air. That's not normal. Mouth open, not normal. You just type in picture like cute baby sleeping and this is what pops up. Like that's not cute. It's not normal. It's a huge red flag, right? Bedwetting. We've had some 9, 10-year-olds that are still wetting the bed every night or every other night. We do their tongue tie, it stops the next day. Again, I only have like 1 hour, so I can't go into all the reasons why, but there's reasons why. Aggressive behavior. Basically, what it comes down to is chronic systemic inflammation, and the 5 leading causes of death are all related to chronic systemic inflammation. So heart disease, metabolic disease, neurocognitive diseases like Parkinson's, Alzheimer's, cancer, all related to chronic systemic inflammation. So we can help these kids not have SDB or OSA. You can impact these things for a lifetime, right? So it's more than just fixing the teeth, more than just taking out mush and putting plastic in, right? So I did a lot of teeth today at the hospital, but and so again, it's one piece of the puzzle. So tongue tie, lip tie, buccal ties up here, but also tongue space. There's enough space for the tongue, right? What's their airway volume? Probably seen the people taking cone beam CTs, that kind of stuff. Retain primitive reflexes. I'd never even heard about this till a couple weeks ago. I was in Phoenix at a conference and I was like, oh my gosh, this is crazy. So the PTs, OTs, chiropractors looking at this. It can, and the reason I put on there is because they had like all these things like bedwetting and aggressive behavior and ADHD. I was like, can be related to retained moral reflex or retained ATNR reflex or retained all these different reflexes, right, that babies have. And so it's interesting to look at that. But also, are they getting quality sleep? Are they on the screen for 7 hours a day, which is the average, which is crazy, right? Are they getting regular exercise? Are they getting outdoor play? Our girls are on a cross-country team, and if they haven't run in the last like few days, like you can see, like they're getting kind of like antsy and stuff. My wife will go make them run, right, in a nice way. Diet and nutrition. Are they eating ultra-processed foods and seed oils and just junk food all the time, right? Have you seen a chiropractor or PT? So here's our child form. We came up with this one. Basically, it's what we saw got better. So every patient, we say, hey, what got better? What got worse? That kind of stuff. And we just added it all up and put it on the sheet. So speech issues, eating issues, sleeping issues, history of issues as a baby, and then other. So these are all tongue issues, right? These are all tongue tie issues for the most part. Lip ties down here. A lot of people come in and they have a gap in their teeth. They have, trouble with BP and M sounds. They fight when brushing the teeth like the 2-year-olds, but they also have a speech delay and mumbling or baby talking. And they're also a slow eater and a picky eater, and they're choking on foods, and they have constipation, and they had a history of issues as a baby, and they have a strong gag reflex, and they're waking up easily or often, grinding teeth. So this child does not just have a lip tie. They probably have a tongue tie and a lip tie. Right? They probably have both because they have like 25 check marks on the tongue side. So it's really based on the symptoms. It's not like every child with a tongue tie has speech issues. Sometimes it's 2 out of the 3. Sometimes it's 1 out of the 3. Some people come in, they have like a bunch of speech stuff, but their eating and sleep are great. That could still be a tongue tie. Other times they come in with slow eating, constipation, picky eating. It's the preponderance of symptoms. So you add that up, right, the symptoms, and then you look at the appearance of it and the feel of it, and then you have a discussion with the parents, right? So we'll talk about that in a second. Adults, it doesn't get better as adults. It just kind of changes over time. So they can have sleep issues, speech issues, eating issues, breathing issues. People like eat like a bird, just like a small appetite. The last one to finish a meal, trouble swallowing pills. They have stress, trouble kissing. Like I don't even have stuff on there like playing a wind instrument. Like that's not even on there. Licking an ice cream cone, making fun of people. There's, it's important, but that's not on here. Poor sleep quality, sleep appliance, mouth open, snoring, CPAP needed, all those things we see in adults. So how do you check? Come from behind. We use a knee-to-knee board. Those are great, by the way, if you don't have one, from Specialized Care Company. They're super awesome. We use them in kids up to about age 10 in the tongue tie center. In the normal hygiene bay, it's like up to age 3 or 4, But up in tongue tie center, we don't have a dental chair, so we use these until they can sit in the chair easily and check them that way. But this way, now you can see, mom can see, come from behind from 12 o'clock position. If you try to come from the front, you're not going to see it as well. Now, this is a pediatric dentist from Germany, came to see us, and her child, she didn't even know he had a tongue tie. But look how tight that is. That's pretty tight. And dad wanted to be able to eat his meat in Germany, right? And so we fixed his. And before they even got home, he was already talking better, eating better, and sleeping better. So she's the one that translated Zungenbahn for us. So here's basically how we do an evaluation on a baby. Might be kind of loud, sorry. That's tight, it's blanching, causing distress to the child. There's the buccal ties. That's pretty tight. This one's pretty tight too. We'll talk about cheek ties in a second. There's dried milk on the tongue. Not obvious tongue tie, okay? Now for this baby, it caused issues, but it's not obvious. So you go see the pediatrician and said there's nothing there. Looks fine, right? Here's another one. Lift up, it's blanching. It should flip up to the nose without hurting the child, without causing distress, blanching. Always check the cheeks. Those are medium. So those could be causing a problem. They may not, depending on what symptoms they have. If they have like milk leaking out, a lot of seal issues, colic, gassy, spitting up, it might be worth treating the cheek ties. It might not. But look at that tongue to the tip and no one picked it up. I mean, that's hard to say. They say WNL, within normal limits. Do you guys know what WNL really stands for? We never looked. Right? Anyway, here's how you treat it. This is a CO2 laser. It's the light scalpel. I don't care if you buy one or not. No affiliation with the company, but it works well. We have two of them, just in case. One is a backup. But so basically, it just hovers over the top. So a diode laser, if you have a diode laser, it gets to 1,000 degrees Celsius, which is super hot, like white hot, and just burns the crap out of it. This gets to 100 degrees Celsius, the boiling point of water. It vaporizes the water molecules inside the tissue, and then it just disappears. Here's the tongue. In just a second, it'll get in focus here. So here's the tongue. It's really thick. It's hard to see there. There it is. And then just lifting up on it, lots of tension. But there's no way you could do that, right? This is an in vivo dissection. So you can see exactly all the layers. You can watch out for blood vessels, nerves. Take it down to the genioglossus muscle, but not take any genioglossus muscle. So it's ultra precise, way safer than like scissors or something like that. At our live course last Friday, we actually had a pediatrician, a functional medicine doctor, and then two pediatric dentists there at the course. And so it was super helpful. And the pediatrician there, I was like, oh, this is cool. She's seeing that they're from Michigan. And she's like, oh my gosh. Like I said, now what would you prefer? Like scissors or the lasers? Like, no, the lasers, yeah, way better. So anyway, here's the lip. Sometimes there's like nothing there. These ones are minimal. This one's all the way down. 94% of babies have a low inserting freedom, but it's not really blanching. So depending on what the symptoms are, that one might be fine. This one's blanching. This one's pretty tight. This one's like notching the bone. This one's got some cords in it. Again, the blanching there. This one's the tightest, shortest one I've ever seen. So they come in all different flavors, shapes, and sizes. For the tongues, this one's super tight and thick. This one's translucent. These two here, do you guys know what happened there? Can you guess? They're real thick. They were cut previously. They were clipped previously by like an ENT or neonatologist or something in the hospital. And they were still causing problems because they never got that back for follow-up. They didn't do stretches, and they didn't see, hey, the tongue is still very restricted. And so really, you got to get away from the thing like tongue tie, because like the pediatrician or whoever, they say this is a mild tongue tie, okay? Their scale is broken, unfortunately. So this is mild. This is nothing. Like, oh, this is nothing. This is nothing. This is the only one that's a true like tongue tie. So again, it's a spectrum of restriction. It's not just to the tip, because even these ones on the bottom, even this one right here was causing a problem for that individual child. Now, if I saw a baby that looked like this on the bottom at the hospital, would I say they need treatment? Certainly not. It depends what the symptoms are. If it ain't broke, don't fix it. But it's helpful to say, hey, mom, it's a little bit tight. If you do have any issues, let us know, right? Because again, these ones got better after treatment. That's how we know it was a problem, because it got better like the next day or minutes later. We have them feed afterward, and often they can tell a difference in the office. So if you just peek under there, can't see much, lift up a little bit more, the fascia bunches together, the connective tissue. You lift up with 2 fingers, that's the easiest way to see it, and then you can see there's a defined string there. Okay, that's the same tongue. Here's the kid on hygiene. So think, well, what do I do tomorrow, right? On Thursday morning, you're going to start checking kids under their tongue, real excited after this lecture, and you're like, oh my gosh, like they all have tongue ties. So who do you treat? Who do you not treat? Who do you recommend? So this one, what's going on here? Not just a fused tooth, but there is a fused tooth, or geminated tooth. So I think it's fused. So anyway, what happens, it's pulling the incisors. So if it pulls O and P inward, there's something pulling them in. Muscle versus bone, muscle wins. So there's something like a little bit hiding out there. You lift up a little bit. Okay, there's something there. But how many kids look like this? Half of them, like a lot of them. There's something there. So what do you say? Hey, mom, do you notice any speech or eating or sleeping issues for Johnny? And then just shut up and listen to what they say. And they'll say, no, he's good. In that case, no cavities. Here's your fluoride varnish. See you in 6 months. Call us if you need anything, right? But if they say, yeah, like, why do you ask? He's been in speech therapy for 3 years. He's the slowest eater. He's so super picky. He's not sleeping well at night. He's grinding his teeth. His teeth are super flat. You notice that on your exam. Then that's more of a place like, hey, mom, maybe we should come back for a full consultation. And then that's when we basically refer them to the tongue tie center, whoever you guys refer them to for tongue ties, or if you still want to start treating these yourselves. But that's what you say, is any speech or eating or sleeping issues, and just hear what they say. We also came up with a questionnaire, a TRQ, the tongue restriction questionnaire. I'll show you in just a minute. But it depends on how you pull on it. Sometimes peek in there, there's nothing there. This is the same tongue, just different amounts of tension. So it's a dynamic structure, and then that's the release afterward. For children, this one had perfect speech. This one was nonverbal. So it's not like a one-to-one correlation. That's what's hard. It's not like your hemoglobin A1C is 6.5, you have diabetes. It's not like that. right? It's not that easy. So this one had terrible time with eating. This one had a lot of neck tension and speech issues. So they caused different things to each one. What's cool is this one was nonverbal. We treated it. He came back the next week and had several new words. So they were super excited, right? This one's to the tip. She had better speech afterward, but again, like, so her speech was good, but she had like less neck tension and better sleeping. So what's important? The symptoms and the function are more important than the appearance, and elevation, how high they can lift the tongue, is way more important than just sticking it out. So like I just did my renewal for the board certified pediatric dentist thing, the ROC, whatever they call it. And it was like some of the questions for the tongue tie module. I was like, I shouldn't even take this, just to make me mad and frustrated. But it's like, oh, if they can stick the tongue past like the wet line, dry line, it's not a problem. That's like totally bogus. That's not a thing. Sticking it out doesn't matter. Almost like Gene Simmons, but some kids can stick their tongue out pretty far and still have a lot of issues because they can't lift the tongue up, right? Look at these ones. So large diastema, I mean, early childhood, severe early childhood caries, a dog leg on this one, blanching. They can't brush the teeth. They're fighting all the time. It's a good service. We do a lot of these for toddlers because parents can't brush their teeth. We had several today at the hospital. Probably 2 or 3 out of my 6 cases had like a very large lip tie, and they had anterior caries. So again, we need a screening tool because we're not just going to treat everyone because we never want to like over treat. We also don't want to undertreat. Right now, we're still probably at a bigger risk of undertreating. There's a lot of kids that have this, have airway issues, have speech issues, eating issues, and it's not picked up. So it needs to be quick and easy because we're all busy. It combines the symptoms, function, parent desires, should be useful, or else what's the point, and should be reliable. And so step 1 is the tongue range of motion ratio. It's how high you can lift your tongue. So you lift your tongue higher than 80%. That's grade 1. That's good. That's considered normal. 50 to 80%, they say it's average, but we have a lot of people that are grade 2 that still have symptoms. Grade 3 is like you can lift up less than halfway. That's pretty tight. That's significantly restricted. And now we're realizing that with compensation, this person would still probably actually be a grade 4. And then grade 4 means you can lift less than 25% of the way. So why do I say that? Because a lot of people are compensating. What does that mean? They're standing on their tippy toes. Okay, they're lifting their tongue up and like the floor of the mouth comes with it. So you can control for that by holding a finger, gentle but firm pressure, holding a finger underneath the tongue, and then that gives you a picture of their true mobility. Let me give you an example. Here's a 39-year-old opera singer, sleeping issues, obstructive sleep apnea, teeth grinding, CPAP, all the things, right? And again, she's an opera singer. That's her job, is to sing well for hours at a time. So she has speech therapy as an adult. She was bottle fed, mouth breathing, reflux, constipation, stress or anxiety, TMJ issues, neck tension, strong gag reflex. Look at her tongue. So not bad. She looks fine. That's why it wasn't picked up for 39 years. When you hold it down, that's her true mobility. So she's probably like a grade 2 or grade 3. But then if you hold her tongue down, she's actually like a grade 3 or grade 4. It's very tight. She can lift maybe a quarter of the way. But look, afterward, holding down, her tongue goes all the way back. And then afterward, holding down, we suture it closed on teens and adults. That's chromic gut suture. Now we're using PDS2. I don't know. The PDS is a lot more expensive. It works about the same as chromic gut. We might switch back. I got a box of it. So anyway, I was trying to build a better mousetrap always, trying to see what we can do. So afterward, easier with sounds, can sing easier. So a lisp because she's sore. Things can get worse before they get better. Less moving at night, less need of a sleep appliance, less grinding teeth, less neck tension, less TMJ issues, less mouth breathing. Posture is better. Singing is easier, less jaw tension. So that's good. She was happy with it. Okay, so that's step 1 is how high you can lift. Step 2 is the tongue restriction questionnaire. We published this in 2021. And essentially, it's the greatest hits. It's like 15 items instead of 50 items. But if they have several check marks on here, and then also how significantly do they impact quality of life? If it's not at all, there's no perceived need for it, well, then they're probably not going to want to do anything, which is fine. Just keep an eye on it, right? You can lead a horse to water. So like, don't talk people into doing a tongue tie. There's enough kids that need it. It's like cavities. Like you don't have to talk them into fixing their kids' teeth. If you tell them they have a bunch of cavities and they don't want to fix them, like your blood be on your own heads, like whatever. It's not off my hands. I've informed you that was my job. So with tongue ties, it's like, if someone had oral cancer, like you need to screen for tongue ties. Like everyone needs a screen for tongue ties. Everyone doesn't have to treat it, but you should be able to identify it, answer questions about it, And after this, like 1 hour, hour and a half lecture, you should easily be able to do that. But if you want to treat it, that's more like 25 hours of teaching. So all that to say, for oral cancer, identify it and then you refer it to the oral surgeon, right? Hopefully never see any cases of that. We haven't seen any cases of that. We've seen some weird stuff on PANS, of course. I'm sure you guys have too. But all that to say, but if it is significantly or very significantly impacting quality of life, there's maybe something to do there. How tight is it? Is it a grade 2? Is it a grade 4? And then referral recommended. So this does not mean they need a tongue tie release. It's not like diagnose them. So your hygienist can have them fill this out. You can laminate it and have it fill it out in the hygiene bay before you even get there. And just take a look and see. Because like, yeah, why'd you ask? So you do this for 6 months, screen all the patients, and you'll know what to do. But what's interesting is make sure you have a plan for all those patients. Because if you're not treating tongue ties yet, like oh my gosh, it's about a quarter of the kids. It's extremely common if you ask the right questions and you're looking at it. So we've kind of gone away from like just asking everyone, trying to bring up tongue ties so much in the hygiene bay, because you don't want to be known like, oh, you're at the tongue tie office. Like, don't go to that office. Like, they're just going to tell your kid has a tongue tie. So there's a balancing act there. So I won't say anything unless it's like pretty tight, or I'll just say like, hey, mom, any speech or eating or sleeping issues? If they say yes, then I'll have them fill this form out. But we don't just have them fill this form out for everyone anymore. But we did for several months. That's why we did the study. If you want to download this form, all of our forms, they're all Word documents. You can change them, put your logo on them. I don't care, whatever you want to do with them. tonguetie.com/professionals, or the QR code right there. So it's really difficult to remember. So tonguetie.com, just click the professionals tag. So some people say, well, how do we know when to treat it? So I give everyone likes a nice infographic. If it's obvious, like it's to the tip tongue tie, they have lots of symptoms, speech, eating, sleeping, it's a slam dunk. It should help them. The chances of it not helping them are very, very slim. Conversely, if it's obvious, like to the tip, and there's just a few symptoms, it's still probably worth doing. That's like low-hanging fruit. This is the one that gets people, though, right here. So it's minimal, not obvious, right? It's just a little bit, maybe halfway restricted, but they have all the symptoms. That's also low-hanging fruit. So really, the only time you're like waiting is like, it's a little bit there. There's not many symptoms, then there's nothing to do. Just wait, keep an eye on it, because it can change over time. So just tell people, hey, mom, if you guys have any issues later on, just give us a call back. Briefly about evidence-based medicine. Don't have time to go into the whole thing of the research. I have hours of that in Tongue Tied Academy. But level 1 is like randomized control trial. Level 2 is cohort studies. 3 is like case control or case series is level 4. Expert opinion is level 5. The New York Times is below expert opinion, in case anyone's wondering. So before Christmas last year, they released a thing. It was the booming business of tongue ties. And they're like, oh, it doesn't help, essentially, and it causes problems, and they're butchering babies, is what they said. So I'll show you that in just a second. But before that, in 2020, this is published in Clinical Pediatrics, Pediatrician Journal. It's a prospective cohort study we did at our office, meaning before we even knew if they're going to get better or get worse, we said, you're in the study, we're going to report it no matter what. 37 kids, first study to show significantly better speech, eating, and sleeping at 1 week and 1 month follow-up visits. Also, improvements in speech delay, never been reported before, picky eating, slow eating, choking, snoring, and restless sleeping. So this is huge because like it's very difficult to do a randomized control trial in your office, especially if you are traveling from several hours away. Can't flip a coin and say, okay, we're going to do yours today. No, we're going to wait 2 months and do it. You can't reasonably do that. So this is about as good as you can get in a private practice. Dr. Gahary, though, did a randomized control trial with babies. And because he was tired of people saying posterior tongue tie doesn't exist, right? It's not a religion. You don't have to believe in it. It's a real thing. Right? They used to think that hand washing used to be controversial. The guy who came up with it, Ignaz Semmelweis, was thrown into a mental institution. Right? He went crazy because no one believed him, that it was causing childbed fever, because killing moms, basically, because they would do an autopsy on someone who just died and then go deliver a baby with not washing their hands, and they're transferring germs back and forth. And no one believed him. So all that to say, randomized control trial. Breastfed babies, but they used a computerized nipple, so they have objective feeding data, right? So often like, oh, well, people say they nurse better, but that's just moms like saying that. No, this is posterior tongue tie, same laser we use, same methods, statistically and clinically significant improvement in 11 objective feeding metrics. Plus, they were breastfeeding better in the treatment group, but not in the control. Reflux improved in the treatment group, but not in the control. Nipple pain improved in the surgical group, but not in the control. So we have a randomized control trial published in the ENT journal, right? Otolaryngology, head and neck surgery. Okay, huge deal. So really big deal. Have you guys ever heard of like don't treat the lip tie before the canines come in because it causes basically scar tissue and you can't close the gap? Have you all heard that before? Anyone? So the pediatric dentistry guidelines said that, and then I was kind of frustrated with that. I submitted 135 changes to the guidelines for the Freenham management guidelines. They accepted over 30 of them, which I was happy with, adding in references, fixing typos, that kind of stuff. But this is the one thing, this is the reason why I did that in the first place, and they did not fix this. And they said, is like the Council of Clinical Affairs, and they said, if you have any evidence to show that it doesn't cause scar tissue, then submit it. Because previously it was just it was a survey. It was not like actual patient data. So we took all the patients we treated from 2015 to 2018. This is when it happened. 192 total patients that had teeth. 109 followed up, had post-op images taken. The width decreased in 94.5% of the patients. So if you do it right, meaning you remove this piece of tissue right here, right here, the part that would be between the teeth, and we can measure it, just like when you do an endo or something. I've done more root canals than I want to this year. But anyway, you can measure, if the perio probe, you can measure the width of a central incisor and you can calibrate it. And essentially, we measured before and after pictures and the width decreased almost all the patients. Half with CO2, half with diode, 13 had permanent teeth, 96 had primary teeth. This is published in International Orthodontics. That's the European Orthodontic Society's journal. And here's some pictures real fast. So this is before, very difficult to brush their teeth. That's one good reason to do it in toddlers, but also it can help the gap close up. And this is with a diode laser. That's what it looks like. So this is probably 2015 I did that one. And the gap closed up and then it closed up more. So which would you rather have, right? It's so much easier to do ortho if you're not trying to squeeze the diastema together and then the tissue is going to spring back open. So they have to have a permanent retainer forever, right? Here's another one. It's the CO2 laser release. Before, after, and then the gap closed up. No braces needed. This is their most downloaded article for almost 2 years, right? And people want this information, right? Here's more pictures. Gap, treated, closed. Gap, treated, closed. Gap, treated, closed. I could show you lots of those. Here's one, no need for braces, right? Closed up, we saved them $5,000, $6,000. 7-year follow-up. You're like, well, they may cause scar tissue. Nope. 2016, gap, we treated it. There it closed up 2016. So September. So like 6 months later, it was already closed. Permanent teeth come in, still looks good. This is in 2023. Briefly, buccal Freenham, buccal ties. We're treating these. Lots of people treat these. 94, where is it? Yeah, 70% of providers are releasing buccal ties if needed. There's 0 articles on it, which is a problem if you get with the dental board or with a legal issue. We have to have some evidence. So what do? You can't do like just a cheek tie release and leave the lip and tongue alone. No one would let you do that. I've asked parents before. I said, Mom, what if I told you, we're only going to do the cheeks today to see what happens, and we're going to leave the tongue and lip alone, which we know they help, right, from studies. No one's going to agree to that. So you're never going to get a study on only cheek ties. However, we did the next best thing. We surveyed 466 healthcare providers over 15 different countries. 87% indicate they do assess for cheek ties. Typically a finger sweep, looking at it, tissue blanching, a functional assessment. You need objective and subjective findings, meaning you need like what's going on, like the symptoms plus the feel of it for the diagnosis. Probably 5 to 10% of babies is what we think. No one knows exactly. Need stretches, and most people are checking them, and you do it at the same time. You're not going to put the baby through a separate procedure. Maybe has some seal issues, aerophagia, milk leaking out. We don't really know for sure. One lady, I did her cheek tie, her tinnitus, the ringing in her ear went away, and she'd had it for a decade, for 10 years. So we see weird stuff like that. That's because of the fascia, the connective tissue. We made a classification system. So class 1 is mucosal, class 2 is in the gingiva, class 3 is at the alveolar ridge. Also look at this acute acrostic I made. So blanching the tissue, is it uncomfortable to palpate? Is there a clinical impact, compensation patterns? Then like, where is it attached? So it's not the first thing you go to. And is it limiting range of motion? Treatment, it takes about 5 or 10 seconds. We don't charge for cheek ties. I think it helps, but if they have lip and tongue, the tongue is the most important. The lip is secondary, the cheeks are tertiary, right? So don't like, some people come to see us like they did the tongue and then like the left buccal. It's like, no, like that's, if you're gonna do the buccals, you do them both at the same time. Don't do one over the other because you don't want to, it's like an asymmetry, like a possible asymmetry. And you would do the lip before you do the cheek. So there's an appendix on treatment in there too. So here's the New York Times article briefly. Inside the booming business of cutting babies' tongues. I didn't realize this, but then like Daily Mail, other people pick up these articles from New York Times, and then like, this is the headline, this is the screenshot. U.S. doctors are wrongly slicing off bits of babies' tongues to make breastfeeding easier, leaving them with lifelong deformities, investigation finds. Oh my gosh, we have to stop these people that are killing babies, right? In other news, here's the best baby formula. All right, the formula industry, $62 billion a year industry, right? Like they advertise a lot with the New York Times or whoever else. So there is some ulterior motives there. They actually asked me to be a part of it. This is the author, Katie Thomas. She asked me to be a part of it. I politely declined. Long story short, I wrote a long response to it. And now if you Google booming business of tongue tie, look what pops up number one, right above the New York Times article. Boom. All right. Technique sensitive. People say like, oh, tongue ties don't work. Well, they don't work if you don't do it right? If you just clip it halfway, there's no follow-ups, there's no stretches, it won't work. It's just like a composite. It's, it's pretty technique sensitive. Prep, rinse, dry, etch, rinse, dry, not too much. Bond, air dry, not too much. Cure, fill, cure, polish. It's a lot, right? And the restoration will not work as well if it's done out of order, right? If you like bond and then etch, it's not going to work. Tongue tie, it's history, assessment, diagnosis, treatment, aftercare, follow-up. It will not work as well if it's done out of order or if you skip steps. So it's really silly to say, oh, the filling didn't work if you do it wrong. It's also silly to say treating tongue ties doesn't work if it's done incorrectly or incompletely. Sadly, for the last several decades, it's just been done like basically wrong or not completely. So if we see this every day, we see ones that have been clipped before or treated elsewhere, even with the laser, it doesn't matter. Some people, you can use the laser and do it wrong. If you just get a little bit, they don't do stretches. So just because you own a laser does not mean you're going to do it right. So you have to have the training behind it, right? So look at these, super tight. If people saw these, I feel like they would have been like, okay, there's like some restriction there, but no one saw them back for follow-up. Then they came to see us because they're still having problems. Here's a 36-year-old, clipped as a baby, still there, right? It does not stretch out. They do not go away. Symptoms can fade and kind of come back over time. This one, they clipped the salivary ducts. That's not good. The baby survived. That's a joke. But clearly, oh, they're gonna like, something terrible is gonna happen. They did okay. They didn't have to have surgery in their salivary ducts, but like it's not good to do that. Here's a couple of quick cases. Here's a 2-week-old, 7 out of 10 pain, awful pain for mom, hiccuping, passy falling out, moving on to sleep, always hungry, falls asleep nursing, pops off and on the nipple, gassy, nose sounds congested. To the tip, no one picked this up. Both parents are physicians. No one picked this up, right? Like you think they would, like dad's a cardiologist, mom's a dermatologist. Like they didn't pick it up. Passy stays in better afterward, more spitting up, less, lip doesn't curl under. Now, why are they spitting up more? Because they're getting more milk out. So their stomach's filling up basically, but the pain is less. Here's the treatment on that same baby. So just hovering above, slow hand speed. The slower you move your hand, the faster it will cut. So most people try to move it too fast. You got to come straight down on it too. You don't want to come from the side. It's a laser. Otherwise, you'll cut in the cheek. So here's the tongue. We're going to lift up lots of tension. Have good isolation. You can see it. And then get all the fascia. Get a little bit more there. You can be super picky with it. It just disappears. It's cutting like the width of a human hair at a time. So it's ultra precise, typically minimal to no bleeding. And now which baby's going to nurse better, right? The one that can move their tongue. Here's a 2-year-old. So dad's an orthodontist. No general anesthesia, no papoose, just topical. So compounded topical, which if you aren't using, it's amazing for Op2, like 10% lidocaine, 10% procaine, 4% tetracaine. And this one, I didn't use a tooth chair. I should have, because I get bit here in a second, which I don't get bit that often. You guys probably don't get bit that often here, but it hurts sometimes. But that one, it's like 10 seconds. So now I always use a tooth chair or a molt mouth prop, a 3.5-inch molt mouth prop. We actually give them to parents to take home for the stretches. So you can get them on eBay for like $4 or $5, 3.5-inch molt mouth prop. Because otherwise, if you do a 2-year-old and you send them home to stretches, they can't get in there, right? So we have to give them a mouth prop to get in. So this one was done with a diode incorrectly. They used silver nitrate to stop the bleeding. Significant post-op pain, nursing strike, and of course, posted on Facebook for all to see. So please don't do this. Obviously, I'm glad they stopped the bleeding, but they went way too far lateral, way too deep. Like there's so much wrong with this picture, and it gives everyone a bad name. So just good, because you own a laser doesn't mean you're going to do it right. Aftercare heals by the secondary intention. They can nurse right away. It's a wet scab, can look like infection or pus. They often drool more. Tylenol or Genexa's like organic Tylenol, or Motrin if they're over 6 months, but you dose it per pound. So anyway, skin to skin, it's like a 10, 11 pound baby. They need 2.25. They don't need 1.25. 1.25 is the 6 pound baby dose. So you calculate it out, milligrams per kilograms, that kind of stuff. Skin to skin, ideally they're nursing sore for a couple days. Often it's better some of the first day or two, but often it's about 3 weeks to relearn. I call everyone personally to check on them later that night. Oh, just remember, I got to call my GA cases from today. I call them too to check on them. If you guys don't do that, it's helpful. It's a good practice builder. And just, I'd rather talk to the parent and then instead of having them call like urgent care or something with a question. So this is what you want it to look like when it's healing. Nice elongated right there, elongated right there. So it's not sticking back together. These ones are sticking back together. There's a horizontal, like a T shape there, or like this one's like a pancake. It's stuck back together. Now start showing parents it's like this. So we're going to cut it horizontally with the laser. It's going to open up like that. And it's going to try to stick back together right in the middle. So if people just push back on the tongue, it's not going to work. You got to push down on the floor of the mouth, then into that crease right between the floor of the mouth and the tongue. That's where it's going to stick back first. If y'all can see where my finger is kind of down first, into it and up. It's almost like a Heimlich maneuver, like you're scooping ice cream. So anyway, but we show parents how to do it before they leave. We have them practice. We have them put on gloves and practice. That's key. So once we start doing that, our reattachment rate is less than 1%, like way less than 1%. Actual stretching time, it's like 10 seconds, just kind of slow, firm, harder than you think, pushing on it, and just kind of hold it back so you can see that whole diamond open up. It wants to stick back on a horizontal line. You want it to have a skinny diamond, and then it's going to heal in from the sides like that. 4 weeks is typically how long we say. 3 times a day for babies. You can stretch too much. If they're doing 6 times a day, that might be too much. We've seen some scar tissue form with six times a day. If they're rubbing it vigorously, that's going to cause a problem. Just slow, gentle, but firm stretching. All right, here's the video real fast. Once you do these stretches 3 times a day for 4 weeks, we'll start with the upper lip, lift it all the way, and flange it all the way out, and massage right on the site. That's really important. Get all the way to the vestibule about 3 times. The tongue, hold the lower gum pad with your non-dominant thumb, push down and stroke backward. Pretty firm right on the diamond. Make sure you get all the way in there. If your baby had cheek tie release, go up on the cheek in the vestibule. On both sides, just about 3 times, the same thing, just kind of separating the tissue out, make sure it looks good. One more time, here it is again, so lift the lip up all the way. It's real quick, not taking minutes and minutes, just get in there and get out. Push right on it, pretty firm pressure. The babies do not like it. If there's a better way, we would do that, trust me. I promise, if there's any other way, we'd do that. That's terrible. Next finger, watch out, see that slip back. So push really good, don't let the tongue slip back, about 3 times right on there so you see the whole diamond open up. Now a deeper stretch, if you don't come back for a follow-up at 1. So watch this, it grew back. This is 3 weeks later, there's still a string there, it came back. It's gonna push down right on the string, just like a normal stretch, but right in the middle. Notice it opened up some. See it stretched out? Stroke it back a couple more times, you'll see it open up some more. There will be a little bit of bleeding whenever you do this, and then it opened back up, but now restore the function of the tongue, and then symptoms should improve afterward. If you do, now we don't have to laser them again. So if someone comes back and it's 3 weeks later, a month later, even 2 or 3 months later, I would always try a stretch first before lasering it again. So stretch first like that, and then most of the time it will just stretch back out, even for kids. So kids twice a day, so like 12 months and up, we consider, toddlers, minimum once a day, but really try for 2 times a day for 4 weeks. Best results, obviously work with speech, myofunctional therapist. See everyone back in a week, especially when you first get started. Most 90% have lost some mobility, need a gentle but effective, we call it deeper stretch. It's really just a normal stretch. We just try not to make the parents feel bad. But here's for kids real fast. Dr. Baxter, we're going to talk about tongue tie stretching. These are on YouTube also. You can put them on your website, I don't care, but they're on YouTube. 2 to 3 times a day for 4 weeks, starting the day after the procedure. Lift up the lip all the way up. Make sure you can see the whole triangle or diamond shape open up. and then massage right on there about 3 times. Pretty firm pressure, like you're massaging. Pretty firm. If you just lift a little bit, it won't work. Flip it all the way up. Okay, just like that. For the tongue, you're gonna hold the lower jaw with the non-dominant thumb. Use your index finger to push straight down in the floor of the mouth and back all the way. If you don't lift it all the way up, it will stick back together. If you don't use enough pressure, it will stick back together. And that one was just done, so that's why it looked like that. But normally you have a white yellow scab. Deeper stretch, 1 time at the 1 week mark, or if symptoms come back, notice there's a T shape on there, like a horizontal line. That's where it's sticking back together. Push straight down. See it open up? Pressure, and it just opens right back up. There will be a little bit of bleeding, however, so keep that in mind. It's not like that. You use a tooth chair on maybe a 2-year-old or 3-year-old, just have them rest their teeth on there. And then you'll notice this one, it was sticking back together a little bit. There's a horizontal line again. So we're going to push straight down and it will just pop back open because it's healed on top, but not below. So push straight down and then it's just open back up. So it's better to do that than having to laser it again. We don't want to laser it again if we don't have to. You have to warn the parents before you do that. Say, hey, mom, there might be a little bit of bleeding, a little bit of red stuff. As pediatric dentists say, just push on. I'll be gentle, though. I'll be gentle and just real slow. And you don't even have to push that hard, and it will stretch back out because they're really not even pushing on it hard at all. Follow up with all patients. Warn there might be some bleeding. Team approach. It's not better. What happened? Haven't seen lactation? No, we haven't seen lactation in 3 weeks. Go back to the lactation consultant. Have we seen the chiropractor or PT? No, we haven't done that yet. These babies are so tight and like this. Part of the problem is they physically can't move easily. They're in fight or flight mode, like attack mode. We need them in chill mode so they can eat, right? So that's sympathetic versus parasympathetic. Seeing the chiropractor PT can help with that. Here's an 8-year-old. So I gave a lecture in San Diego back in February. And like the week before, I was like, I need to get some videos just for patients to update them. And so one day I got like eight or so videos. And this is a couple of the cute ones that were funny. So this is an 8-year-old girl, slow eating, some constipation, restless sleeping, mouth open, trouble breathing through her nose. What's interesting is after we do the lip tie on like almost every adult and a bunch of kids have said it too, that they can breathe easier through the nose. It feels like you got some Afrin. Mouth breathing during the day. She had issues as a baby with nursing. Look at that. Issues as a baby. You don't treat it. They don't get better, right? It sometimes get better, but like often they have issues later on. So we did her lip tie and her tongue. Which kid's going to eat better, talk better, sleep better? The one that can lift it halfway, the one that can lift it all the way, right? So here's mom's story.
She had a lot of sleeping, very restless.
Can you turn the volume up a little bit, Richard?
Can you hear it at all or no?
It's a little quiet. Like you're loud, but the video's not.
Yeah, this one's quiet. Could y'all turn up on your end? I know. I'll whisper.
Stuffy nose cleared up immediately. She can breathe a lot better. She's sleeping with her mouth closed now. There's not so much mouth breathing during the day. And she even said that she can move better and has had really good results. Very little bit of pain just immediately after the procedure, but really none since. Doing wonderful.
What do you think?
Well, I think that it's so hard to explain, but I can do everything a whole lot better. I can turn my head like this, and I can do this, and I can do this, and I can do this, and I can even do this.
Whipped your tongue out now, perfect. Good. And then what else did you notice when you left the office? What did you say about your nose?
Oh, I could breathe through my nose like the second I got in the car. I think it was like the best relief ever.
That's amazing. Could y'all hear her? Kind of.
Better.
You could hear her? Okay. I can't turn it up anymore on my end. Okay. So then the same day, I did not know these people were coming that day, but same day, here's a 5-month-old male. Like, look at this. Do you think they're on the struggle bus? Like, look at that. They have like every check mark, right? They've tried 30 different brands of bottles, rice formula in there, saw IBS CLC, pediatric dentist, admitted to the hospital, 9 different professionals, ENT, hiccuping and chewing the nipple and snoring and moving on their sleep, mouth breathing, colic, reflux, spitting up, on Nexium. Every bottle he spits up except for at night. Like he won't finish his bottles, all the things. So he already had a lip tie and a tongue tie treated, but it wasn't a full release. So here's the pictures. This is how he presented to us. Lip was treated, but it grew back. Tongue was treated, but it grew back. So we released lip and tongue, and then his cheeks were pretty tight. So we did those two because they traveled a long distance. I don't want to like make them come back. A week later, less reflux, less falling asleep, deeper latch, milk leaks out of mouth less snoring, which is huge, less moving asleep, babbling way more, blowing raspberries and squealing now. So it affects their speech even that young. Typically, it's 2-month-olds and up. We do it for feeding reasons. They often have better speech afterward. Mom's now hopeful instead of depressed, she said. 4-year-old, this is brother, 4.5 years old. This is the same day, obviously. He wants his tongue fixed so his friends can understand him. He's really shy. He has lots of speech issues. He's on the age of a 2-year-old. They thought he has autism, doesn't tick all the boxes, mom said. He has constipation, won't try new foods, picky eating, choking or gagging on foods, slow eating, issues as a baby, saw 7 different providers again, wets the bed, sleeps in weird positions, grinds his teeth the whole night, snores half the time, tonsils out, adenoids out, all the things, right? Now look at his. So his lip, it's fine. His teeth are together. It's not blanching. We just left it alone. His palate, yeah, I could use some expansion. He's pretty narrow. But look at his tongue. His tongue only lifts halfway. So which kid's going to eat better, talk better, sleep better, right? The one that can lift all the way or halfway, okay? So here's mom's story. Can y'all hear this? Okay.
My friend Jaden, I've got a 5-month-old as well. Dr. Baxter just did Jaden's tongue tie release a few seconds ago. He's already speaking better after 2.5 years. Speech therapy, tonsils taken out, seeing ENTs, dentists, vacuum consultants, a whole lot, and everyone showed me away, tells me there's nothing wrong with my son.
So there's nothing wrong with your son.
On the age of 2-year-old. Seconds after Dr. Baxter did the procedure, he said thank you to the doctor, and we said it much better. I think we do have work. And then Baynant, which is 5 months old, had a deep snore. He couldn't keep his milk in. He drank now a little bit. No leaking on the corners, and he's not snoring at all. Seconds after the procedure. Awareness needs to be made. Thank you, Dr. Baxter. This is going to be life-changing, and I'll forever be grateful.
Where are you from?
South Africa.
They flew to Alabama from South Africa because they could not get help locally. It's not a coincidence that he's eating better and sleeping better and no snoring and the kids talking better. If you treat it right, it works, right? I had a gum graft done. Here's the Dallas story. I had a gum graft done here locally and I had it done twice and then it was not working. So I went to Pat Allen in Dallas and had it done the right way. And I said, what are the chances of this working? He's very wise. And he said, if you do it right, it works. So it's true though. If you do it right, it works. If you don't do it right, it doesn't work. So we have a map at our office. People from other countries can put their pins on the map. And so, yeah, they're from South Africa. So that was cool. Here's one more. This is just a couple days after that happened. It's a 7-year-old with cerebral palsy. She had born with tetralogy of Fallot, had a repair at 6 months old. Her left ventricle exploded. She was 53 minutes with no pulse. They said she was an ECMO. She has a 1% chance of surviving a surgery. Surgeon was shocked. He's like, say goodbye. She's not going to make it. She survived it, had another surgery, like less than 1% chance of surviving, survived that too. And now she has HIE, CP, all the diagnoses, can't eat, G-tube, like hip dysplasia, can't lateralize her tongue, coughing when she eats. She has terrible constipation, suppositories every day for 7 years. Zyrtec every day for 7 years. She can't breathe through her nose. Sleeping crazy, adenoids out, TMJ popping, all the things, right? But no one checked her tongue because everyone just looks at the primary diagnosis. Oh, she can't eat, she can't poop, she can't sleep, she can't talk because she has CP. Or is that true? So we actually have a case series I'm writing up now. We have 4 kids with CP. I just had another one this week, so maybe I'll add him to the case study, but the case series. But all these kids with CP, they all improved afterward. Stuff you wouldn't believe. I don't have time to go into it now, but here's the lip before, lip after. Tongue before stopped, now it goes all the way back. Cheeks were pretty tight. We released those because she had so much fascial tension. And so we released those. They came from Ohio. And then here's the story from mom that same night.
This is my daughter, Elizabeth Robinson. We were just in today to see Dr. Baxter. It's January 31st, and my daughter was born and at 6 months had a massive cardiac arrest, and as a result, HIE, CP, all the labels came that followed. She, since then, after 6 months, has been suffering with severe reflux, constipation, this snorkeling, like she sounds like she has a cold all the time, on Zyrtec for 7 years. She's 7 now. And we've done all sorts of therapies, flew down to Orlando. A therapist quickly identified she had multiple ties, and it's a feeding therapist, and she goes, she will do so well releasing this. Flew in from Orlando this morning to see Dr. Baxter in Alabama. He released the upper lip, the side cheeks, the tongue, and literally, when we were in the car, she was breathing again, not snorkeling, breathing comfortably. Her face looks so relaxed. She pooped, which is amazing because we've been on planes and trains and automobiles, and that would not happen. I mean, just the start of, I could see success. I am so grateful. Where we've been bumping into walls, we can see hope, and praise God. Thank you, Dr. Baxter, and we will look forward to all the gains. Thank you.
So this is why we enjoy treating tongue ties, right? I enjoy doing fillings too and crowns. I don't mind that. But like people, it's not like these kind of stories typically. Occasionally it is. But here's the story. She said, "Thank you both for your God-given wisdom, care, expertise. My life was changed in 2 days because of you both. 7 years I've been told lies. As of today, 2/1/24, I can breathe, I can eat, I can drink, I do not throw up, I can poop. My hips are loose. I do not need to take medication for allergies because I don't have them. Don't have to take suppositories so I can poop. The list goes on. Bless you both, your families, everyone that works with you, all those you help." So there she was. So how do we do this? We need a team approach with lactation consultant, release provider, orthodontist, dentist, speech therapist, PT, OT, myo, chiropractor, ENT, pediatrician, sleep physician. I'm sure there's others as well. But team approach. If you just do it yourself, just like lasering people and then like, bye, see ya, it's not going to work as well. You're not going to get the same results. So what are the takeaways? Proper assessment and evaluation are critical. Ask the patients to lift the tongue, not stick it out. Symptoms and function are more important than the appearance. Common does not mean normal. Just because something is common, like cavities are common, but they're not normal or optimal. You shouldn't have cavities, right? Colic is common, but it's not normal. This can help colic. Screening should be conducted at health hygiene visits, well child visits. The sooner it's addressed, the more team members, the better. They must be assessed, diagnosed, treated, and followed up properly. They change over time, can last a lifetime, and they place significant limitations on a patient and family's quality of life. It affects the whole family. And so if you want to get in touch with us, there's our phone number, email, tonguetied.com/professionals. You can download a copy of Tongue Tied for free, download our forms for free, find more information about the courses, stuff like that. So I have some time for questions. If y'all have any questions, happy to answer those other than this material or other stuff. If you have a question about some patient you had or something, but hope that was helpful.
Thank you so much. Dr. Hal Stewart is going to ask the first question, and then I've got another mic for anybody else.
Oh, great. Yeah.
Yeah, Richard, how you doing? Thanks so much.
Good. Thank you.
Probably got a couple hundred child and adult releases now under my belt, and I primarily suture everything, but over the last year or so, there's been occasions where I do not suture the upper lip or the lower lip. I always suture the time, but not the one, the other suture the time. My question is for adults, stretching exercises on lip when you do not suture. What do you recommend?
So briefly, I'll talk about sutures and then your question. So for babies, for kids, I know some people suture babies. I don't teach that because it takes it from like a difficulty level of like a 3 to like a 10. That's way more difficult. But so we suture basically teens and adults. But if I have a cooperative 8 or 9-year-old and the parents want to suture it, I'll suture it. The benefits of the sutures are you can wait about 4 days to do stretches typically. You still have to do stretches with sutures. So I had Dr. Zaghi do mine back in February, flew out to Los Angeles, had him do it. Still have to do stretches. So I'm not sure if you can see there's no string. I did it right finally. I actually did it myself the first 2 times. But anyway, if you want something done right, do it yourself. I couldn't do like a filling on myself. That'd be way harder, but I could do a tongue tie. Anyway, moving on. So you do have to stretch. That's a common misconception. You can do sutures, you don't have to stretch. So anyone will say that. And also you want to do myofunctional therapy. If you're doing like 10-year-olds and up, 13 and up, you want to do myofunctional therapy. Although you can certainly do it as young as age 4, typically. For the sutures, we switched from the chromic gut to the PDS2 sutures, hoping that they would basically not dissolve as fast, which they're supposed to take like 3 or 4 weeks to dissolve. They still fall out, and like the tissue is just so friable. They still fall out in like 4 to 10 days. And so you still have to do stretches there. Now for the lip, if you're doing a lip on someone, to your question, you have to start stretching the next day or else they'll stick back together. Or if you do the tongue and you don't stitch it, you have to do stretches the next day or else they'll start sticking back together. It's sore though. It's pretty sore to do stretches. They don't like it. If I tell the parents, if there's any other way to do it, I promise we would do that. If you could put numbing jelly on it and make it not hurt, we would tell people to do that. But it just makes them cough and then it doesn't feel good and it still hurts even with the Oragel or whatever they can find. So one person this week, though, she said that they used the 2% viscous lidocaine, like Magic Mouthwash. She said that was better. If you put Oragel on it, it burns. But so maybe some viscous lidocaine might be a little bit better way. But again, an under 2-year-old, you're not going to be able to do that. So if it's like an 8-year-old or something, you could consider that. But sutures, I would stretch for an adult or teen 6 weeks probably. For a child, 4 weeks is the longest you can reasonably expect someone to do that. Twice a day is the most you can expect someone to do it, stretch a toddler to do a halfway decent job, and then 3 times a day for babies. So did that answer your question?
Well, maybe I should make this up clear. I suture almost everything. I won't do a release without myofunctional therapy. My wife has infants, obviously, they're not doing myofunctional therapy, but this is primarily for children and adults, let's say children over 8 years old. No suture on the lip. I always suture the tongue.
Yeah, no suture lip. I don't do that.
On occasion, we won't suture the lip. I'm doing more and more where I do not suture the lip. So, say for an adult, the stretching, I loved your analogy of scooping an ice cream. It's great. Or an adult with no suture. You start the next day with the scoop, and you do it, 3 times a day? 2
to 3 times a day is good. I wouldn't. You can do it too much. If you're stretching 6 times a day, that's too much. 2 to 3 is good. There's a joke in dental school. Everything in dentistry is like the answer is 2 to 3. It's like how wide for your border molding? Like 2 to 3 millimeters. Like how many? Like whatever the answer is 2 to 3. But yeah.
Yeah, that answers it. Thank you.
Okay.
We've got another question in the back, Dr. Train. Is it on?
Yeah, I can hear you.
Okay.
I can't hear anymore.
Hold on, let me switch out the mic. Okay.
Sorry.
This one is on.
Your mic, Blair, is working a lot better. I can hear yours very clear.
Okay, can you hear me now? Yeah.
I can hear better, yeah.
So I've been talking to some friends who are pediatricians, and I talked with them about who they refer to for tongue ties. And they have gone to lectures at UT Southwestern where the head of ENT says that the laser is bad, it causes deformities and scarring, and there's literature in the medical, in their medical journals that convince them not to have a laser frenectomy, and I just want to know your thoughts on that.
Yeah, it's bogus. It's not true. So there is one article that I'm aware of. There's only one article. It was actually a randomized control trial, so level 1 evidence. It's called HATAC 2006. It was published in the Journal of Periodontology, so a good journal. They basically looked at people who were having a tongue tie release done with a scalpel or like traditional, like a blade, or with a CO2 laser, and afterward, better patient perception, less pain, like less post-op and during pain, and better healing is what they said. HATAC 2006 is the article, but they won't care. They just don't want to do it. Essentially, the problem is, if you look at a pediatrician's, like their EMR, they're like GI. And if anything was wrong in that section, GI, it's like reflux, constipation, send to the GI doc. Tongue tie falls under ENT. right? ENT said anything's wrong with their ears, their nose, their throat, their tongue. It falls under that. They click a button and it refers them to the ENT. It's like so mindless, right? It's not like, so you do not even go talk to the pediatricians about it. Don't even talk to the ENTs about it. If you're looking to get started, I would talk to lactation, talk to speech therapists, talk to myofunctional therapists, and the people on the ground working with the child every week. The chiropractors are really open. PTs, OTs are really open because they see the benefits afterward if it's done right. Now, I will say, if you do it with a diode laser, it's 1,000 degrees Celsius and it's a hot tip, that versus scissors on a baby, I almost would rather do scissors. Now, for the lip tie, that's different. But for the tongue, you're going to get a decent amount of thermal damage. It takes about a minute per area with the diode laser, unless it's an X-lace, which is faster, but it costs like $18,000. So at that point, you might as well buy a CO2 laser. But if you're using like the pen, like we use the iLace, it's about $3,000, or at least it was a while ago. That's probably more now with inflation, but it's like the pen laser. We used that for 18 months and it was terrible. I enjoyed helping the families, but I was like, this sucks, this sucks, this sucks, this like a cut. It was just taking so long. So I would choose scissors probably over that. I've only ever done some scissor releases in Nepal when I was there for a dental mission trip and didn't have a laser. So I choose scissors. It works. You get more bleeding, but you have to use a hemostat first. So all that to say, yeah, don't listen to everything they say. In the AAO consensus statement from 2020, I also wrote a thing about that. And the AAP just came out with a clinical report, which is not guidelines. I know because I talked to people who wrote it, Maya Bunnick and Jenny Thomas, which are not nice people. I did a Zoom with them back in February because I was talking to the California Society of Pediatric Dentistry, and they thought it'd be a good idea to get us on a Zoom together, the two pediatricians and me, to talk about our diverse viewpoints. I was like, this is going to be a crap show. This is not going to be a good idea. It was terrible. But all that to say, yeah, just don't worry about it. Just do your thing. Thankfully, the AAPD guidelines are very like structured and good and give us a lot of latitude to do what we're doing. And so if there was ever an issue with the dental board or with anyone else, you're very well covered with the AAPD guidelines. So I hope that kind of answers your question. They're like, oh yeah, I was at a pediatrician conference. We had like a booth there. I was brave. That was 5 years ago, probably. And I offered to speak. They didn't want me to speak. They asked an ENT to speak who hadn't even asked to speak. They just asked him, like, hey, will you come talk on it? And he put up a picture of like Dr. Evil and said frickin' laser beams and was like talking about me. So yeah, anyway, we get it. But we help the patients, and like you can check, we have over 1,000 5-star Google reviews. So, I mean, if we were just lying to people and tricking them, I could tell so many more stories. But like, we would have all 1-star reviews. Briefly, I was with Dr. Zaghi in Detroit last year, and it was like a debate. And we invited the pediatricians to come. It was the Michigan Academy of Pediatric Dentistry. Invited all the pediatric dentists to come. They showed up. Invited all the pediatricians. This many showed up. 0 showed up. They didn't want to hear it. They would never listen to this. If you send this to them, they will not listen to it. Guarantee you. Guarantee. They don't want to hear it. It's like, la, 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 you know. So Jonathan Walsh was there. He was the author of the clinical consensus statement for the ENTs, right, in 2020. He was the second author. He's like Mr. Anti-Tongue Tie, or Dr. Anti-Tongue Tie, right? And I asked him, I said, how many do you do? He's like, 1 a month, maybe. 1 a month. Like that. I do 10 a day, you know? And so he's not, what he'd rather, like, what's the big deal? Just cut the string and like move on. So afterward, he listened to my lecture, Dr. Zaghi's lecture. Zaghi's an ENT, enlightened ENT. He's in Los Angeles. He does mostly kids and adults. So, and I said, Jonathan, what do you think I should do? Should I stop doing them tomorrow? Because it's not evidence-based. He said, Richard, the problem is we don't have a way to explain what you're doing, like why it works so well. I was like, do you have to know like why it works? Like, do you have to know like, you know, how they make a hot dog or hamburger to know it's like delicious, you know, or whatever? Like, it worked for this one, it worked for the next one. So they said, we can't explain it. So what's the fascia? It's like, well, I don't know. I explained it's the tongue mobility. But so I said, what should I do then? Should I keep treating them or should I stop treating them after hearing my 3-hour lecture? He said, well, clearly what you're doing is working. So keep treating them. So, okay, so I have your permission here, your blessing to keep treating patients on Monday. He said, yes. I said, okay, great. So once they hear it, they're like, okay, like it's the truth. You know, if I was just lying to you, it'd be very obvious. But anyway, you can come see it. That's why I can have a course. This spring, we had a course every Friday. We had a course that I was in town, and we had people come see, and you see exactly what we do, and you see the results. And it's like almost every patient's having like these good results if you do it right. Some are mixed results, like, okay, it's a little bit better, but then over the course of the next few weeks, it gets better. So hope that answers your question.
Yes, we have another one. The green light.
There we go. Okay, now it's working. Hi, Dr. Baxter. Thank you so much. I learned a lot. Really appreciate you teaching us tonight and taking time out of your schedule. Just to make sure I understand, this is not really something we were taught in dental school. With your CO2 laser, you are making a similar or the same cuts that you would with a scalpel. Is that correct? You just like it because the healing is better, there's less bleeding. Better. Am I understanding that correctly?
Yeah, so they don't teach it in dental school. They don't teach it in residency. They also don't teach tongue ties in medical school, in pediatric residency, in ENT residency. They don't teach, like, there's like, just cut it. What's the big deal? Move on. So the light scalpel, or any CO2, so there's Solea. If you have a Solea, that works. Dr. Cotwell uses Solea. Dr. Gahary uses light scalpel. Zagi uses light scalpel. I use light scalpel. Pia Gandhi and Houston use light scalpel. So a lot of people are using that.
What is that? Is that the
Would-
brand?
That light scalpel is the brand. Yeah.
Brand of.
It's just a CO2 laser. There's DECA, there's light scalpel, are the two soft tissue, and then Solea is hard tissue, so you can cut preps with it. Solea costs $150,000 plus an $800 a month maintenance fee. So to buy a light scalpel and pay, if you were to like make payments on it, I think it's $800 a month. I don't know. I paid for it with dental money. So a common argument is like from the pediatricians, like, oh, he's just doing it to like make money for his laser payment. Like, no, I paid cash for it in 2016 from like dental money. And by the way, dentistry is more productive than doing tongue ties. Like if I would do dentistry, and now the overhead's less with tongue ties. I need a staff of 14 people, to do the same as I can do with 2 employees with tongue tie. But anyway, that's a different story. But the production is about the same. And I think the pediatricians hate that because like they see, 30, 40 patients a day and make like, I don't know, not nearly the production that pediatric dentistry makes. So I think they're jealous in that regard. That's part of it, I do believe. Or like ENTs will take out tonsils and adenoids and get like $200, So that's part of it. But all that to say, the light scalpel is like the best blend of, or just the CO2 wavelength is the best blend of cutting efficiency as well as hemostasis. So we don't have time to go into it. The Tongue Tied Academy course goes into it more, but essentially, diode laser is really good at hemostasis, but also has thermal damage. It's really slow at cutting. An erbium laser, like a Lightwalker, like the erbium YAG laser, there's several others. I plus, like Waterlace, the BioLace I plus, those cut hard tissue, but they also do soft tissue. Those are really well absorbed by the tissue. So those cut even better than CO2, but they have worse hemostasis. So this allows an in vivo dissection. It's very controlled, very precise. When they say it's causing damage or scar tissue, they're thinking like a diode laser maybe. That's not what we're doing. So not all lasers are not the same. But yeah, if you're interested more, like the best way to learn it is like Tongue Tied Academy. The way I've made it this is like the course I wish I had before I got started. That's why it's 25 hours. I don't care if you buy it though. It's not, we donate all the money. So like if you buy it, that's good. I think it helps people, but no skin off my back if you don't. But I think it's the easiest way to start learning about it. Because if you just go to like a conference like Breathe and Thrive, which I'd highly recommend, it's in Clearwater in January, end of January. I'll be there. There'll be lots of other people there, and you can learn a lot there. But it's not set up to like teach you how to do it necessarily. It's everyone's giving a different presentation. So this is like the A to Z treatment is Tongue Tied Academy. So hope that answered your question, kind of. But yeah, there's a lot of benefits to doing it. You can see better. You can get a full release. It's quick. Because if you cut it with scissors on a 2-year-old, they're gonna be bleeding and like getting blood on your walls everywhere and all over their clothes and all over the parents. And it's not, I mean, you think about like when you take out D, E, F, and G, right? And if you like ran out of gel foam, it's like that. So anyway.
Hey, Dr. Robinson.
Hey.
Baxter, sorry. This is more of a personal question. You mentioned tinnitus and somebody that had vocal releases and her tinnitus went away. Can you tell me, I guess, a little bit more about that case?
Sorry, which I couldn't, it kind of cut out a little bit. Which case was it?
The lady that had, I guess, tinnitus, the ringing in her ears.
Oh, yeah. Yeah, so I think we did her tongue tie and her lip tie, and she was sleeping better afterwards. She was doing myo. She was probably 50. And then she still had like the ringing in her ear. And she's like, do you think the buckle tie could impact it all? So the only thing we did was her cheek ties, right? Because we'd already done tongue lip. It was at a follow-up visit, like maybe a month or two later. All we did, and then like the thought is that it's the fascia. So when you release the lip tie, it releases the fascia throughout the midface, and that's why they breathe through their nose better. When you do the tongue tie, it releases the fascia, like connective tissue, like the stuff you pull off a chicken. And it's one piece of continuous fascia from your tongue all the way down to your toes. It's called the deep layer of investing fascia. And when you release that, like people move their neck easier, like babies will move their neck easier. That's why they start walking better. One kid was playing baseball better. I said, if I start advertising that like you can get sports improvements from this, like all the parents in Alabama, you know, like it's football is like religion here. So they'll be after us. So all that to say, all I did was her cheek tie and the ringing in her ear went away like within an hour or two. I don't know. That's the only case I have like that though. I just say we see weird stuff like that. It might help. I mean, it's like minimal risk, like for the 2-year-old. The 2-year-old's not talking, not sleeping well, not eating well. The tongue like lifts pretty high, but it's maybe like 20% restricted. So my conversation with the parents, like, hey, mom, I think there's a good chance it'll help. We have lots of room for improvement. We could see improvement in any of these areas. We might get 1 out of the 3. We might get 2 out of the 3 areas. We might get all 3 areas, right? I just don't know. But hey, if I had to take him to put him to sleep at Children's like we did today, they're going to get 4 bills from Children's. You increase the anesthesia risk. They got to take another day off work. You know, we can do in the office with a CO2 laser. That's another reason we use it because, again, if you use a diode laser on a 2-year-old, you won't have to do that many times to realize that's not like the videos I showed you. It's 10 seconds versus a minute. It's so much easier. If I had to do a filling, like a facial on E or something, on a 2-year-old versus a lip tie and a tongue tie, I would much prefer to do lip and tongue. It's way easier. All that to say, that's the laser technology has allowed us to do this and minimize the risk. The biggest risk is going to stick back together, and then they paid the money. It didn't help as much as they wanted to, but that almost never happens. So with the tinnitus, yeah, it's worth a try. It's minimal risk. There's no real bunch of structures up there going to mess up. Might help. Any other questions?
Anybody else? We might have time for one more. I know we're preparing. If nobody else,
Thank you again, Dr. Baxter. I always love listening to your lectures. I think you do every time.
Thank you.
About the deep stretch that you might do at the 3-week mark. So I've had a couple of those where they reattach to that point. So is that setting back your clock? So are you telling the parents that at this point we have to start from week 1 again, if we're doing it for 4 more weeks?
So it's all psychological, right? So we used to say 3 times a day for 3 weeks. And then we got everyone back at 1 week or so, 7 to 10 days. And then we did a stretch on them and then it opened back up. And I'm like, oh, now we need 3 more weeks. So now I say 4 weeks because I'm guessing they probably didn't do it right the first week. So push on it, pretty good. Do the best you can. See them back in a week. Now they have some frame of reference for it. So now when you stretch it, which it's not even pushing that hard. That's why I don't like the term deeper stretch. I came up with that term, but like I don't like it anymore. It's just a normal stretch. But I say deeper stretch, so they don't feel bad like they've been doing it wrong. But no one pushes hard enough because they don't want to hurt their kid. I say I don't want to hurt them either, but I also want it to work for you long term and not just be better for a week. So often it's good if they have, you know, something better at a week, like they're sleeping better, like they're just still, they're not moving around a lot, there's less snoring, they're talking better, something like that, then that's at least gives them some positive things like, okay, the stretches suck, but look where we're getting, right? And then hopefully by the end of the 4 weeks, they're doing better. So now, again, now we've changed it to, instead of saying 3 weeks, we say 4 weeks up front. First week, they're not going to do it right. Now, when you stretch it, it opens back up. Hey, mom, 3 more weeks, you're doing great. So that's the secret. So just tell them beforehand it's 4 weeks. And then when it opens back up at a week, you're good.
anybody else? I have one quick question for you because we do have a lot of, so it's dentists in the room, orthodontists, we've got chiropractors, PT, OT, myofunctional therapists, SLPs. I wanted to ask to see if you have looked into any comparisons with your babies that have done the body work, either pre or post-operatively, and if you've seen in your experience improvement long-term.
So I'll tell you short term, 100,000%, the ones that have seen the chiropractor, PT, OT, and are not in fight or flight mode and are chill and relaxed, they do way better for the procedure. Like they calm down quicker afterward. An easy way to tell, you can like shush the baby, shh, and try to calm them down afterward. And the ones that have seen the chiropractor or PT, like within 1 or 2 loud whooshes, they're quiet and silent. They've calmed down. The ones that are in fight or flight mode, it takes about 5 or 6 or 10. Like you just keep like, shh, like the baby will not calm down. Their nervous system is like in high alert, right? And so those ones, they do better for the stretches. We see more improvements quicker afterward. So if someone comes back to see us in a week or 2 and says that it's not better, nothing's better. So have you seen the chiropractor? No, we don't believe in the chiropractor. I'm like, okay, well, like it's not crack. It's very gentle. If they're killing babies, it'd be on the news, you know? So, hey, we have a really good physio baby is here. They actually have some people in Houston. Not sure about Dallas, but I'm sure there's some good PTs. Dallas is a big city. So we have physio baby now, and like they do amazing work with babies, and it's very similar. It costs a little bit more because they spend more time, but it helps the babies just relax and chill out. So we have seen better improvements, and probably long term too. I mean, I see the chiropractor. I think it's very helpful, especially as a dentist. But yeah, I think it does help the baby short term as well as long term. But there's like no studies on it, like body work versus not body work. It'd be a good study, but it probably won't happen.
Well, anybody else before we wrap up? I know we're at our limit now, so I don't want to keep you. Thank you so much again.
Yeah, just email. Thank you. Thank you. If you do have any questions, just email us, info@tonguetie.com.
Awesome. Thank you so much. I'm going to go ahead and end the call, and then we'll have this recorded too for anybody in our group that wants to see it afterward.
Perfect. Awesome. Good to see
Thank
you.
you.
I'll be in Dallas.